So, guys, good evening and a warm welcome to all of you in today's session. I expect that all of you have been staying very healthy and in high spirits and also revising medicine, whatever we have discussed in the previous classes. So, today we are going to discuss about some of the important MCQs. I have framed these MCQs from the perspective of Foreign Medical Graduate Examination, INICET, and NEET PG examination, right? So this is going to be a very interesting session. I expect everyone to participate in the chat session. So guys, before we start, I really request all of you to show me your presence in the chat box so that we can start today's session, guys. I'm waiting for your replies. So guys, here comes the first question. Please read this question carefully and let's try to sort this question. Good evening, Rahul. Good
So guys,
evening,
here
Dr.
comes the first question. Please read this question carefully and let's try to sort this question.
So good evening, Alpna. Good evening, Priyanka, Rahul. So guys, let's do this question and let's understand what they are asking. So you have 1 minute time. Okay. Now I think the technical thing has been sorted out. So let's see what is your answer. So let's read this question. Guys, I have told you earlier also how to read the MCQ and how to approach an MCQ. It's very easy. First of all, we have to read the last line what the examiner is asking from us, right? And then we have to read the options. If we follow this practice, trust me, guys, your subconscious mind is going to tell you a lot of things that what the language of the question is going to happen. So let's read the last line first. They are asking what is the initial treatment, right? So they have given us options like DC cardioversion, amiodarone, metoprolol, flecainide. So all these drugs we know where they are used. They are the cardiac medicines, and particularly they are used in the treatment of rhythm disorders, particularly for atrial fibrillations, right? So let's read the question. That a 70-year-old male, 70-year-old patient, non-case of bronchial asthma, presented to you with the complaints of palpitation, which started approximately 1 hour ago, and he has a history of congestive heart failure. On examination, heart rate is 176, irregular, blood pressure is 118 and 76, respiratory rate is 22 per minute, ECG is suggestive of atrial fibrillation. What is the initial treatment? Hanji, Bhushanji and Rahulji, you have given me, Priyanka, you have given me the right answer. So guys, let's discuss why it is going to be the right answer. First, why it is not DC cardioversion. We know it very well that DC cardioversion can be used, but DC cardioversion is only used in unstable patients. कहाँ पे use होती है बेटा? In unstable patients, mean hemodynamically unstable. So where the blood pressure is on a lower side, there only we are going to use this cardio version. But in the question, if we read carefully that how much is the blood pressure over here, you see that how much is the blood pressure, right? How much is the blood pressure? It is going to 118 of 78, right? And some more, there is no history that the patient is unconscious or something like this thing. So we can consider this patient as a very stable patient. So obviously, cardioversion is not going to be the answer. Okay, metoprolol is not also the answer. Why metoprolol is not also the answer? Read this line carefully that it is a non-case of bronchial asthma. So we know this that beta blockers are going to cause some bronchoconstriction, right? So if you give this type of drugs, metoprolol, atenolol, right, all these drugs are going to be there. They can cause bronchoconstriction. Now, flunacid is the drug. This one D is the drug which is most likely to restore the sinus rhythm in atrial fibrillation. But there has been trials. Particularly, if I talk about, there is a CAST trial. What trial, beta? It is also documented in good books of cardiology that it should be avoided in the left ventricular failure. So avoided because of heart failure. Now, here there is a history of heart failure, and it can be an arrhythmogenic post myocardial infarction. So, we are only left with the anti-arrhythmic drug. What is that drug called as? It is, yes, what is this drug, beta? This is amiodarone. So, yes, Dr. Priyanka, Bhushan, and Rahul, you have given me the right answers. I really appreciate. So, let's move to the next question now. Let's read this question carefully. I am waiting for a 1 minute time and then we will proceed further. Okay, so let's read this question. Which of the following drug is not recommended in the acute treatment of this patient? So it is not recommended. Please focus upon this thing. It is not recommended in the treatment of this acute patient, right? So options we have low molecular weight heparin, ramipril, atenolol, and glyceryl trinitrate. These are the options. So what is the question? You are posted on a night duty in emergency where a 30-year-old man presents with sudden onset of central crushing chest pain, which radiates to the left arm, which occurred while dancing in a party. ECG is suggestive of ST elevation in the inferior leads. So before we get into the question, I request all of you, can you please make the diagnosis? What is this patient is having? Obviously the answer is, it is patient is having myocardial infarction. But my question is not that, because it was also already mentioned that in the question that this patient was having myocardial infarction. My question to you is this, guys: what is the mechanism of this myocardial infarction? हाँ जी, ये बताइए, what is the mechanism? बताओ दोस्त, क्या हो सकता है ये mechanism इसका? How did this myocardial infarction occurred in a very young patient? Young because it is only 30 years. Myocardial infarction occurs in 30 years. I agree to this point, but it is rare, guys. Right? Generally, myocardial infarction occurs after 40, 45 or maybe 50s, somewhere like this thing. 30 years पे हो सकता है, I am not denying this, but थोड़ा rare है. अगर हुआ है, if the myocardial has occurred, then there is a clue, or there is a pathology lying in this question. I wanted to know what is this, why this 30-year-old guy had a myocardial infarction. Please tell me. I am waiting for your replies, guys. हाँ जी. See, let's read the question carefully and understand why myocardial infarction. See, the patient occurred while dancing in a party. Now, this party word is very important over here. This party word is very important over here. Maybe that patient is an substance abuse. There are high likely chances that this patient had a substance abuse. And what kind of substance abuse? Maybe a cocaine abuse. Maybe a cocaine abuse, right? So cocaine is basically a potent sympathomimetic agent. So cocaine क्या होता है बेटा? It's a potent sympathomimetic agent, right? What does it do? It basically it basically acts by preventing the reuptake. So it basically inhibits the reuptake and accumulation of dopamine and noradrenaline. Dopamine and noradrenaline. Right? Now, we know this. If there is a dopamine release, what it is going to occur, my dear friend, where it is going to occur at the sympathetic junction. कहाँ पे होता है ये? At the, sorry, not sympathetic, at synaptic junctions. At the synaptic junction. तो इससे होगा क्या? There will be a positive effect on that alpha adrenoreceptors. There will be a positive effect upon the alpha adrenoreceptors, and this will cause vasoconstriction. And this is going to cause vasoconstriction. Yes, you are right that sympathetic activity is going to create. I agree with your point, but I am trying to explain you the whole mechanism. Now we know that if there is vasoconstriction, the coronary blood flow is reduced because of the vasoconstriction. The muscles of the heart, the myocytes, are not going to receive adequate amount of the blood, as well not adequate amount of oxygen. So what is going to happen? Myocardial infarction is going to occur, right? Because there is a mismatch between the demand and the supply of the oxygen, right? Okay, so let's talk about one by one. I am not going to hit. Yes, what is the answer, guys? So Yogesh, Prakar, Priyanka, Tiwari, Rahul, you have given me low molecular weight heparin. Guys, low molecular weight heparin is not going to be the right answer. because understand the concept, we have to use this low molecular weight heparin very cautiously in the patients who are abused of who are cocaine abused. Why? Because in a patient with a long standing cocaine abuse, there is a higher risk of intracranial hemorrhages. So if the patient is having a risk of intracranial hemorrhages, some more you have given low molecular weight heparin anticoagulant, what will happen? The condition is going to get worse, or if not, then maybe there are chances that the patient is going to have hemorrhagic kind of stroke. So this is not going to be the answer. Okay. Atenolol is not going to be the answer, guys. Atenolol is not going to be the answer. See, because beta blockers, they are going to aggravate the vasospasm, right? They are not going to be the vasospasm, and they are going to create the vasospasm also, and they can worsen the ischemia in this case. So we are only left with one. We are left with glyceryl trinitrate. So the treatment of cocaine induced MI is basically glyceryl trinitrate. Do remember this thing, and calcium channel blockers. Calcium channel blockers. CHBs, CCBs are going to be the answer. So this is the explanation. Do remember this thing. If you find any question where there is a history of substance abuse or there is some history of party, do expect particularly young patient and MI is occurring, guys. Do remember that in this question there is a hidden clue that is called as the substance abuse and cocaine induced MI. You're going to treat with nitroglycerin. So this was the question. Okay, can we move to the next question? Any queries? Yeah, okay. Rahul, I really appreciate that you brought into my knowledge that in the question asked not recommended. So this can be given, this can be given, this can be given. Strictly, if not recommended, guys, then obviously my answer is going to, okay, sorry, I went into the explanation and forgot to tell you that this is going to be the answer. This is going to be the answer. Not recommended, totally not recommended is atenolol. My answer is atenolol because I told you atenolol or the beta blockers are going to aggravate the vasospasm and they are going to worsen the ischemia. Where there is a little risk or risk of intracranial hemorrhage with low molecular weight heparin, so use it very cautiously. And we have to choose ACE inhibitor or calcium channel blockers. I really appreciate your presence, Rahul. Thank you very much. Any other queries upon this? Okay, can we move further? Let's read this question. Okay, Ji. So what they are asking from us, what is the likely cause? And options we do have is mitral regurgitation first, tricuspid regurgitation, aortic regurgitation, and aortic stenosis. Okay. So you are a family physician of a 65-year-old man. He presents to you with complaints of increasing frequency of episodes of dizziness on standing. On examination, you note a slow rising pulse, very important, slow rising pulse, and a systolic murmur that radiates to carotid. Hanji, what is the answer going to be? What is the answer going to be, guys? So there is a 65-year-old man and he is having dizziness on standing, right? And a slow rising pulse and a systolic murmur that radiates to carotids. So, Dr. Rahul, can you rethink? I am requesting you to change your answer. फिर से एक बार चेंज कर. Okay. Let's discuss the characteristic features one by one. Let's discuss about the characteristic features one by one. So first of all, we do have that option of mitral regurgitation. So let's make a chart. Let's make a chart, guys, and we will understand the concept clearly, that what is the characteristic features. First of all, let's write on murmur, kind of murmur. What we are going to find on auscultation. What we are going to find on auscultation, right? And it is associated with. It is associated with. So the first very option, we had what beta? We had mitral regurgitation. So let's discuss about mitral regurgitation murmur, MR. What do you find in a case of mitral regurgitation? What kind of murmur does it have? Hanji. So the first of all, mitral regurgitation is going to be a pan-systolic murmur. It's going to be a pan-systolic murmur, right? Then it is loudest at the apex. Loudest at apex. And characteristic feature is this, that it radiates to, Hanji, can you please tell me where does it radiates to? It radiates to, it radiates to axilla, right? So it is going to radiate towards the axilla. So these are the characteristic features where you are going to find on auscultation, right? Whereas it is associated with, first of all, it is associated with atrial fibrillation. One thing, do remember this thing. And it is also associated with the displaced apex beat. So it is associated with displaced apex beat. So now guys, can you please tell me, is there anything which is suggestive? Is there anything among this in the MCQ which is suggestive of that the answer is going to be MR? No. Why? Because it is going to have a slow rising pulse and a systolic murmur. Systolic, not pansystolic murmur. So we are out with this option. We are out with this option. Second option we do have is tricuspid regurgitation. What option we had? Tricuspid regurgitation. Right. So tricuspid regurgitation. Now tricuspid regurgitation is again going to be a pansystolic murmur. It's again going to be a pansystolic murmur. Very important to know, right? It is loudest at, हाँ जी, loudest at कहाँ पे होता है बेटा? Loudest at, people has given me okay, Rahul, you gave me answer B. Now tricuspid regurgitation was upon option number B. So I'm going to explain you this. It is going to be loudest at the lower left sternal border. Lower left sternal border, right? And there is no radiation. This doesn't radiates. It does not radiates. So in the MCQ, This murmur was radiating towards where, beta? This murmur was radiating towards the carotids. So we are also out with this tricuspid regurgitation. Some more, when they discuss about the tricuspid regurgitation, there is a giant V wave. Particularly, they ask, there is a giant V wave in jugular pressure, jugular venous pressure, and it is also associated with right ventricular heave. Right ventricular heave. Right? So we are also out with this option, tricuspid regurgitation. Now we are left with what options, guys? We are left with aortic regurgitation. Okay. Now aortic regurgitation is again, guys, where is this aortic regurgitation? Anji, let's discuss about aortic regurgitation. Aortic regurgitation. It's early diastolic murmur. It's an early diastolic murmur. First of all, very important thing, it's heard best in holding expiration, while holding the expiration phase, right? And where it is heard best, at the lower left sternal border. Lower left sternal border, right? It is associated with collapsing pulse. It is associated with a collapsing pulse. These are the characteristic features of aortic regurgitation. So that's why, my dear, aortic regurgitation is not going to be the answer. So Yogesh, Bhushan, you have given me the right answer. Some of you have given me the right answer. So the right answer is going to be the aortic stenosis. So what are the characteristic features of aortic stenosis, guys? Hanji, what are the features of aortic stenosis? Let's discuss this. Aortic stenosis is going to be, it's an ejection systolic murmur. It's going to be an ejection systolic murmur. The very important thing, it is loudest over the aortic area. And this particularly radiates to carotids. It radiates to carotids, right? It is associated with a slow rising pulse. One thing, it is associated with dizziness, and it also associated with a displaced apex beat. So it is associated with a displaced apex beat. So these are the characteristic features of aortic stenosis. So guys, so we are going to have the answer aortic stenosis D as the answer. I hope you have really revised some kind of murmurs. Can we move further, guys? Now let's jump to the next question. Quickly read this ECG and tell me what is in this ECG. They are asking what is the likely cause and the causes are hypokalemia, hyperglycemia, hypermagnesemia, hyperthermia. I am zooming this. Look at this ECG. So guys, I hope you have gone through with this ECG. So let's read the MCQ. That an unknown person is brought to you triage by an ambulance from a nearby bus stop where local passengers informed about the sudden collapse. Below given is the ECG. What is the likely cause? Hypokalemia, hyperglycemia, hypermagnesemia and hyperthermia. So first of all, guys, I request you to please tell me what is in this ECG. So if you are able to interpret this ECG, it's very easy to answer this question. Very basic ECG. हाँ जी. बेटा क्या है इस ECG में? रिदम के अलावा बेटा कुछ और देखो. No, I am okay. Don't jump into the options. I am asking what is in this ECG. I am just going to zoom it now. Okay, forget about ECG. Particularly focus upon this lead. Lead number 2. This is called as long lead. So can you please focus upon this? I am zooming it now. Let me help you. Is this P okay? Is this P okay? Okay. Q okay? Okay. PR interval is okay. 1, 2, 3. Okay. QRS okay. ST T is okay. Everything is okay. PR थोड़ा सा तू कह सकता है कि प्रोलॉन्ग्ड, बट नहीं यार, नॉर्मल है PR. बट यहाँ पे अगर तू देखेगा ना, Q से लेके T तक, कैन यू प्लीज कैलकुलेट द टाइम बिटवीन द Q एंड द T? हाँ जी, look at the time of the Q and T. So guys, what is happening over here? There is a prolonged QT. क्या है बेटा यहाँ पे? Prolonged QT, right? So we have a prolonged QT interval. Now once I have told you there is a prolonged QT interval, guys, now can you please tell me what are the causes of the prolonged QT interval? Particularly if we are going to talk about some of the metabolic causes. हाँ जी, if we are going to talk about the metabolic causes, then you have to answer me what are the metabolic causes. What are the metabolic causes? कौन कौन से causes हो सकते हैं? So first of all, the metabolic causes are going to be, right, this is going to be the answer, right answer, hypokalemia. So we have hypokalemia, hypocalcemia, hypokalemia, hypocalcemia, hypocalcemia, then hypomagnesemia, hypomagnesemia, right? We have what you call it as hypothermia, not hypothermia, not hyperthermia, hypothermia. Fifth one is hypothyroidism. hypothyroidism. So these are some of the metabolic causes you have to keep always in mind, guys. And there are some other causes like drugs, particularly like amiodarone, sotalol, quinine, terfenamide, terfenadine, right, tricyclic antidepressants, right, and erythromycin. So these are some of the drugs, guys. In Harrison, it is a beautiful chart. I expect all of you to revise that chart, right? And some of the syndromes like there is an autosomal dominant syndrome by the name of Romano-Ward syndrome, right? So guys, when you're going to revise the ECG, please go through this table. This is the important table, and it is an expected table to be asked in the question in your examination. चलो आगे चलते हैं. Okay. So, what is the most likely cause? And the options we have is pulmonary embolism, performance anxiety, hypertrophic cardiomyopathy, acute myocardial infarction, right? So, a 24-year-old male was participating in athletic tournament where while participating in 400-meter race, he started having a central chest pain. He reports that his uncle was also a sports person, right? And he suddenly died at the age of 27 while participating in the state tournaments. What is the most likely cause? Guys, before you proceed into this, question you have given me, Rahul, Prasad, and Bhushan, you have given me the right answer. See, guys, it's very easy to understand a question if they are asking hypertrophic cardiomyopathy. What are the characteristic feature of hypertrophic cardiomyopathy? Is this that there is always a history of sudden death in the family. This is the important history, right? So, hypertrophic cardiomyopathy, as in this question, there is a suddenly died at the age of the person's uncle has died suddenly at the age of 27. So hypertrophic cardiomyopathy, my dear friend, that there is a genetic condition. First of all, it's a genetic problem, right? Means it is autosomal dominant. This thing you have to remember, right? This basically affects the cardiac myocytes. Many patients are asymptomatic, they remain asymptomatic, but when they start doing some physical activity very aggressively, the demand of the heart muscles or the myocyte increases, but due to large volume of the heart, the demand is not properly supplied or catered, right? And then they start going into ischemia. If we talk about the investigations, ECG can be done first, but the definitive investigation or a non-invasive investigation is going to be the echocardiography, where you can actually rule out what kind of cardiomyopathy is going to be there, right? So maybe there is some hypertrophy is there, right? You can see the ejection fraction also. You can also see if there is some septal hypertrophy, then there can be obstruction to the aorta. So patient can have sudden what you call it as decrease in the blood pressure. This can occur, and this can also come in the questions, right? If we talk about the treatment of this, then the treatment medical management, we have to give like calcium channel blockers, CCBs. We can give beta blockers, right? And we can give anti-arrhythmic drugs. If all this management is not giving much of relief, then surgical myomectomy is recommended in a case of hypertrophic cardiomyopathy. Point I wanted to make it very clear: whenever you are going to encounter a question of this one hypertrophic cardiomyopathy, do remember the examiner is definitely going to give you history of sudden death or probably a cardiac death in the family, and that person who died or who presented to you with the complaints, he must had some kind of aggressive physical activity. Only after that all these symptoms are going to be occur. Now, I have told you that majority of the patient are going to be asymptomatic, but when the patient is going to present to you, then they will most likely present with sudden chest pain or palpitation or central chest pain, as in the MCQ is mentioned, right? So I think we have done with this MCQ. So let's continue with the next question. Please read this question. So guys, look at this picture. Haji, I have zoomed it now. Can you please tell me what this patient is going to have? Okay. So let's read the question. You suspected infective endocarditis and order an echocardiography. Most likely, where do you expect the vegetation to occur? So first of all, it's a very easy, MCQ. Already the examiner is giving you the diagnosis that this patient is having infective endocarditis, right? And from this question, it is very clear that which valve is most commonly involved. So in infective endocarditis, so mitral valve is going to be the answer over here, right? But my question to you is this: what is this called on on the tips of the what do you call it as nail tips? So let's understand the language. A 35-year-old man present to you with the complaints of fever, rigors for last 10 days. On examination, temperature is 102.4, heart rate is 116, and you observe below this. So guys, what is this? This is called as splinter hemorrhages. What is this called as, beta? Splinter hemorrhages. So this is splinter hemorrhages, right? Now, my question to you is this: that you have suspected infective endocarditis, right? So what is that decreasing order in frequency means? What is the most common valve to be involved in a case of infective endocarditis? Although we know the answer, it is mitral valve. MB is the most common one. This is the most common one, mitral valve, right? Then we do have aortic valve. Then we have both the mitral valve as well as aortic valve, right? Then we have tricuspid valve, and rarely we do have pulmonic valve. Rarely we have pulmonic valve involvement in a case of infective endocarditis. So this is the answer, that mitral valve is going to be the answer over here. And we also know this thing that approximately 70 to 75% of the cases of infective endocarditis are caused by which species, guys? Hanji, I am asking, which species is most commonly responsible to cause or to get the involvement of the mitral valve in a case of infective endocarditis? So the answer is going to be, it is going to be streptococcus. Streptococcus, right? चलें आगे, can we proceed further? Okay, ji. So let's read the question now. The most likely organism to be suspected. So the organisms we have is Staph aureus, gram-negative Bacilli, coagulase, negative Staphylococcus, and no growth. A 60-year-old man who was under cardiac surgery, who underwent cardiac surgery for a mitral valve replacement approximately 2 months back. Very important, guys. This line is very important. Approximately 2 months back, now presented to you with complaints of tiredness, lethargic, and fever. On examination, his febrile heart rate is 118 per minute, blood pressure is 116/78. On auscultation, he has a metallic first heart sound and a late diastolic murmur heard over the apex. We have just discussed about the murmurs. You take multiple blood cultures from different sites, that is must needed. And what is the most likely organism to be suspected? Okay, ji. So, Bhushan sir and Dr. Prasad, you have given me a right answer. See, guys, what happens approximately, there are 10 to 20. So, this is going to be the answer. The Staph aureus is going to be the answer. So, 10 to 20% of the patients, 10 to 20% of all cases of infective endocarditis are associated with the, of infective endocarditis, they are associated with prosthetic valves. So they are associated with prosthetic valve. This percentage you have to remember. Now, among all these things, eventually 5 to 7% of the cases they come with the complaints of infective etiology. Right now, guys, this line is very important, that approximately 2 months. Now, see, this is a little tricky MCQ, that approximately 2 months. We are not sure that it is below 60 days or it is more than 60 days. Maybe there it is 50, 55 days, approximate, like maybe it is 65 days. So we can have two answers in this question. So be very careful in reading the MCQ. I have framed this purposefully to make a point over here. If you encounter a question that it is less than 60 days, the presentation is less than 60 days, right? Then the answer is going to be coagulase negative Staphylococcus is going to be the answer. What it is going to be, guys? It is going to be a coagulase negative in a case of less than 60 years. In a case of not years, 60 days. But if they have particularly mentioned that it is more than 60 days, after 60 days, the patient is presenting with all the features of infections like fever है, patient को lethargic है, all these tiredness, ये सारा कुछ है, then definitely, my dear friend, the answer is going to change, and then answer is going to be the Staph aureus. Then the answer is going to be the Staph aureus, or maybe it is going to be the beta hemolytic streptococci. Right, this you have to remember. Right, so do remember this thing, how much is the time duration they have mentioned. If it is less than 60 days, the answer is going to coagulase negative staphylococcus. But if they are mentioning more than 60 days particularly, then your answer is going to be staph aureus or alpha hemolytic streptococci. Another point to be remembered over here, that all the maximum of the what you call it as metallic walls are likely to become infective in the first 3 months of the implantation, in the first 3 months of the surgery. Whereas the bioprosthetics, so metallic valves, MV, they get infected within 3 months, right? Whereas the bioprosthetic valves, they are likely to get infective in a 1 year of time. So this is 1 year of implantation. Within 1 year of implantation, if they get infective, so this is another important point, guys, you have to remember. Okay, ji. So can we proceed further to the next question now? So let's read this question. ECG finding is not indicated for thrombolysis, right? Which of the following ECG finding is not indicated for thrombolysis? 70-year-old man is brought to emergency with complaints of central chest pain, right? Which of the following ECG finding is not indication for thrombolysis? So from these lines, what do we have understood? We have understood that this patient had some kind of myocardial infarction, right? So let's see what is your answer, guys. Yashwant, okay. A. Anyone else? Bhushan A. Prasad A. Okay. So let's talk about some of the important features of just a second, guys. Indication of thrombolysis, very important. Put a star mark over here and make a note that what are the indications of thrombolysis. Indication of thrombolysis. The first very indication is new onset of LBB, new onset of left bundle branch block. First indication, right? Second is ST elevation, ST elevation more than 2 millimeter in two or more contiguous chest leads, contiguous chest leads. This is another indication of thrombolysis. The third very important indication is ST elevation of greater than 1 millimeter in two or more limb leads, two or more contiguous limb leads. Contiguous limb leads, right? The fourth very important indication is posterior infarction. Is what beta? Posterior infarction, right? So these are the indication. Now we have discussed about all the indications. Those, can you please tell me that what the answer is going to be now? So the answer is going to be yes, A, because here it is written that greater than 1 millimeter, two or more contiguous chest leads, chest leads. Whereas we require this one, ST elevation greater than 2 or more. This is going to be the answer. For chest leads, it is going to be 2 millimeter, 2 millimeter for chest leads, and for limb leads, obviously it is going to be 1 millimeter. So these all B, C, and D are going to be the indications, whereas option A is not going to be the indication. What ECG finding you expect that a 60-year-old patient had an inferior ST elevation MI, right? Inferior ST elevation, very simple question. I'm expecting right answers from you guys now. And I'm pretty sure you all are going to give me the, right answer. हाँ जी guys, very simple. Bhushan ji, very well said. Okay. So guys, basically what this patient is having, this patient is having what you call it as inferior wall MI. Inferior wall MI. It basically involves what beta? It basically involves the right coronary artery. It involves the right coronary artery. We know this thing, right? And the ECG finding, it is going to be, ST elevation in what you call it as lead 2, 3, and AVF is going to be the answer. Lead 2, 3, and AVF is going to be the answer. So guys, let's quickly revise what kind of MI we see, and what are the what you call it as areas in the ECG where you find the changes particularly. So I will write guys, and you have to tell me the areas, right? You have to tell me the areas. I am going to write type of MI, and you have to tell me that what ECG finding you find. Okay. So this is type of MI, ECG changes, right? And what is the vessel involved? What is the vessel involved? So guys, can you please tell me that the most common artery involved is left anterior descending LAD territory is going to be involved if we talk about the vessels, and what kind of MI it is going to have? It is going to have anterolateral MI. So anterolateral MI. What ECG findings? Where you are going to find the ECG findings? Hanji, I'm putting this as a question mark. So let's discuss about the ECG changes, ST elevation, where in which leads we are going to find the ECG changes. No, Bhushan, I agree that anterior leads. So can you please specify what anterior leads? I want to hear from you. So basic, my dear friend. Okay. So we are going to find changes basically in lead 1 AVL, right, and V4 to V6. These are the leads we are going to have some changes. So lead 1 AVL and what do you call it as V4 to V6. Okay, then we do have anteroseptal MI. Anteroseptal MI. Again, which vessel is going to get involved? And LAD territory is going to get involved. Left anterior descending, it is going to get involved, right? ECG findings will be mainly seen in V1 to V4. V1, V2 will be Bhushan, I agree with your point, but overall V1 to V4 will be involved over here. I agree with your point, beta. I agree. Okay. Then if they ask you about the lateral MI, only lateral MI, right? Then it is left circumflex LC is going to get involved. Can you please tell me in lateral wall MI, what are the ECG changes? In which leads you are going to have the ECG changes? Hanji, V5, V6. Okay, I will write V5, V6. What other? बेटा limb leads भी बता दो. Okay, lead 1 AVL. Lead 1 AVL. Okay. Next one we have inferior wall MI. Inferior wall MI. Hanji, I just told you that the vessel involved is what beta? Right coronary artery is mainly involved over here. And in inferior wall MI, what we are going to find the changes in lead 2, 3, and AVF. Lead 2, 3, and AVF are going to be the culprits, right? So these are the some of the important type of MI, guys, high likely to be asked in the your examination. So guys, I expect you to this have on your fingertips, and always you should carry this information in your brain, and rock the show in the exams then, right? Okay, I hope you have done with this slide. We can move further with the next slide. I am giving you 1 minute time to read this question carefully and then reply me. Guys, let me make this question. It is not the most likely, it is the least likely, because I have two answers. It is the least likely. It is the least likely. It is the least likely. Now, can you please tell me? Guys, I just looked it into this question. There was a printing mistake. It is not most likely, it is least likely. Please read it least likely. I know you were giving me the right answers. Now I have changed. It is the least likely, guys. So, guys, you were giving me answer as B12 deficiency and iron deficiency anemia. I agree. These were the most likely causes. I totally agree. That's why we have two answers in the options. That's why I changed it to the least likely. And when we have these two as the most common, we are only left with folate deficiency. So basically, guys, what this patient is having, yeah, obviously, Abhimina, this least likely is folate deficiency, and I totally agree because initially it was written most likely cause. So people who have given me the answer as B12 deficiency and iron deficiency, I totally agree with their point. I appreciate your answers. Okay, so basically, guys, what this patient is having, let's see, HV is having, let me read this question. A female with generalized weakness, tiredness, low energy, and shortness of breath on exertion. Why she is having? Because she is having a low hemoglobin, and hemoglobin, it carries oxygen. So because of that, shortness of breath and tiredness and low energy also, she is experienced from last 5 to 6 months. On examination, everything seems to be normal apart from this pallor, conjunctival pallor. HB is on a lower side, right? MCB is increased, WBC is on a normal side, platelets are on normal side. So obviously, what this patient is having, this patient is having macrocytic anemia. This patient is having beta macrocytic anemia, right? Okay. Let's discuss about some different causes. Let's discuss about some of the different causes of macrocytic anemia. Different causes of macrocytic anemia. So let's discuss about the causes. First, we will discuss about megaloblastic, normoblastic, or then we will discuss about hematological abnormalities. So let's discuss about that where we do have normoblastic. Can you please tell me normoblastic macrocytic anemia causes? Can you please tell me about the normoblastic anemia? What are the causes, guys? हाँ जी, प्लीज बताइए. What are the causes of a normoblastic anemia? Waiting for your replies, guys. Okay. So it is, first of all, it can be pregnancy, right? Alcohol, liver diseases, liver disease. There can be reticulocytosis, reticulocytosis, right? I appreciate your answer, Abhimina. Okay. And then myxedema also. Myxedema also. So, what are the causes of megaloblastic anemia? What are the causes of megaloblastic? Hanji guys. So the causes are going to be, we know, B12 deficiency, B12 deficiency, right? Then folate deficiency, B12 deficiency, folate deficiency, right? We have drugs like, methotrexate. We have drugs like methotrexate, azathioprine. So drugs like methotrexate, azathioprine, like hydroxycarbamine, hydroxycarbamide, and then we have cytosine. So these are the causes for megaloblastic causes, and then we do have some hematological causes. Hematological causes. So guys, can you please tell me some of the hematological causes of anemia? It's like aplastic anemia, aplastic anemia, myelomas, myelodysplasia, myelodysplasia, myeloproliferative disorder, myeloproliferative disorders, right? So these are some of the causes. So guys, quickly revise through this slide, then we can proceed further to the next question. हाँ जी guys, very simple question. हाँ जी guys, so what is the answer? So let's discuss where do we see what kind of cell, what is the most common, which of the following is the most consistent feature of iron deficiency anemia. So we know this thing that the pencil cell is going to be the right answer. So pencil cell we see, where we see in iron deficiency anemia, let's discuss. So pencil cells in iron deficiency anemia we see, right? Where do we see these bite cells? Bite cells are basically seen in G6PD deficiency, glucose 6PD deficiency. Where do we see this teardrop cells? Hanji, where do we see this teardrop and where do we see this oval cell, guys? Guys, quickly reply. Okay, ji. Right. So we, yeah, obviously we see this, oval cells. Where do we see this oval cells? Hanji, guys, I'm waiting for your replies. Guys, Hanji, where do we see oval cells, guys? Very simple. So we see this oval cells in megaloblastic anemia. In megaloblastic anemia, one thing, right? And where do we see this? What you call it as teardrop cells. Hanji, teardrop cells. So we see this teardrop cells, guys. Particularly, we can see this, in likely in iron deficiency anemia, it can be seen. But more likely, we see the pencil cells. See, remember this thing, pencils. The RBCs are round, round, round. But when they got elongated like this thing, this is called as pencil cells. So teardrop cells can be seen in iron deficiency anemia, some hemolytic anemias, right? And we can see also in cancerous disease, in carcinomas or in some metastatic diseases. So this was about that the basic question. So let's move to question number next. So guys, let's read this question carefully. Right? What is the next step in the management apart from withholding warfarin? Right? So just by reading this question, we can make some statement that withholding this warfarin means somewhere this patient is at a risk of bleeding. That's why the person is going to withhold the warfarin. And in the options, what options we do have? We do have subcutaneous vitamin K, protamine, oral vitamin K, fresh frozen plasma. We know we use this when there is a bleeding diathesis, all these drugs, right? Okay. So now let's read this question. A 60-year-old man who's a known case of recurrent pulmonary embolism and is on, guys, you have to just give me a moment. I think my pencil got disconnected. Just give me a moment, guys. Okay, we are back. Okay. So, guys, a 60-year-old man is a known case of recurrent pulmonary embolism and is on warfarin therapy for last few years. Visits you for a routine checkup. Okay. He has a history of hypertension. On examination, you don't observe any bleeding. Very important, guys. You don't observe what? You don't observe, read this line carefully, bleeding or bleeding related skin changes. His lab reports WHV is 14 normal, WBC is normal, platelet is normal. Is INR normal or not normal? Is this INR is going to be normal or not normal? First of all, tell me. INR is not normal. Those INR यहाँ पे क्या है? The INR is increased. We are expecting. See, what do we expect that the patient is on anticoagulant, particularly when the patient is on warfarin. The target INR. We have discussed this in the class. How much is the target NIR? Target INR is between 2 to 3, right? But here it is 8.6. It is highly raised. But the good news is this, that there is no bleeding. No bleeding, only INR is increased. What is the next step in the management of with apart from withholding the warfarin? हाँ जी बताइए. You have given Tripati A, subcutaneous vitamin K, D. Okay, A. You are giving me answer A or oral vitamin K. No, you have to choose one. Those choose one. Shivani, you are giving fresh frozen plasma. Okay. Okay. So guys, understand very simply understand the concept over here that the right answer going to be, what it's going to be oral vitamin K. Now, why I am choosing oral vitamin K as the option over here, right? First of all, that this patient is not having any kind of bleeding. This is one good news that this patient, despite of a high INR, this patient is not having, bleeding or bleeding related diathesis whatsoever, right? Now, only thing is that he is having a raised INR, right? People may live a normal life even with raised INR, right? Now, trials between, there are lot many trials who have reported us or who have documented evidence that equally there is a equal good effective between giving the subcutaneous vitamin K or orally. Now, if they have a equal effect, then why to prick the patient, guys? Unnecessarily, why we have to prick the patient, right? So guys, subcutaneous, because based upon a lot of studies, I don't recommend this subcutaneous. Oral vitamin K is going to be the answer. Now, protamine sulfate. Protamine sulfate is, what you call it as, it is the antidote for heparin. This patient is not heparin. Why fresh frozen plasma is not going to be the answer? See, fresh frozen plasma is not going to be the answer because there is no immediate bleeding or profuse bleeding where we need to control on a very immediate effect. That's why fresh frozen plasma is also out. Over treatment of all these things, if you start giving subcutaneous, you start giving fresh frozen plasma, chances of weaning of the whole effect of warfarin will be gone, and chances of hematoma related things will start occurring over here. That's why be very patient and be very smart enough to choose whatever you are going to choose in a case of person who is on some anti anticoagulants, right? So the answer is going to be the oral vitamin K. Thank you. Okay, Tirupati, I got your answer. Okay, okay. See your answer. I appreciate your answer, sir. Let's read this question. Which among the following is the least likely cause? And what are the causes? Prothrombin deficiency, protein C and S deficiency, factor 5 Leiden, and antithrombin 3 deficiency. Where we have read all these things, we have read this in pulmonary embolism. Right? Now let's read this question. A 33-year-old female has recurrent episode of headache, and on investigation, you diagnosed her to have a sagittal sinus thrombosis. Okay, very good. Approximately 1.5 years ago, she had a deep vein thrombosis for which anticoagulants were given for months. Her mother had a history of DVT. Her mother had a history of DVT. She denies the use of OCPs, alcohol, or any other substance abuse. Her examination is unremarkable. Which of the following is the least likely cause? Do remember they are asking beta least likely cause. Now, understand the concept over here. This patient is basically having what beta? There are 2-3 main important things. That sagittal sinus thrombosis is there, DVT की history है यहाँ पे, and already the patient has been on anticoagulants for quite a few time. Another important history is this, that this female has some family history of DVT because mother had this one. So it means there is a chances that this patient has developed inherited thrombophilia. Inherited thrombophilia. First of all, this patient is having inherited thrombophilia. It is quite possible that there is a thrombus which is going to the towards the brain, and which is causing what do you call it as blockage to for the blood to go into the brain, and that's why the brain is not receiving adequate amount of oxygen, and the patient is having some kind of headache. This is quite possible. Obviously, it is written in the MCQ that the patient is having sagittal thrombosis and some more DVT is there. Now, point I wanted to make over there, that what are the causes of inherited thrombophilia? We know this thing and we have discussed in the class about all the causes. So, guys, I am asking the least likely cause. Protein C and S deficiency is the cause. Factor 5 Leiden deficiency is the cause. Antithrombin 3 mutation is the cause. Prothrombin deficiency. Here, please read this question. It is prothrombin deficiency, whereas the most common is prothrombin gene mutation. Prothrombin gene mutation is the cause, not the deficiency. Right? So prothrombin gene mutation is the cause, guys, for inherited thrombophilia. Do remember this thing, not the deficiency. So this was the clue. This was the clue. Right, guys? If still you have any queries, any questions, guys, I expect you to please put me on the Unacademy, what you call it as, page, and you can get with all your queries and your questions cleared or your doubts cleared. Right. I hope that you have enjoyed this today's session very well, and we try to figure out all the aspects. So, guys, all I want to say is this: keep on revising the thing. Medicine is easy only when you are going to revise it again and again on routine basis with a consistency, right? It's not so tough. So don't be afraid of anything. You have that zeal. You have that, what do you call it as, spirit to be the rock star of your college and the rock stars of your profession. So, guys, thank you very much. I wish you all the best. We'll see you in the next session. Thank you, guys. Take care. Good night.